The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us, in person or virtually, at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Welcome back, everyone, to another episode of APIC's The 5-Second Rule. I'm Silvia Quevedo, your host, and I'm thrilled to be with 3 great panelists today to talk about an important issue, and that is diversity, equity, and inclusion. Yeah, that's a big topic also for infection prevention and control and patient safety. We have a lot to unpack today, so I'm going to get right to it. I want to welcome our panelists, starting with Dr. Tania Bubb. Hi, Tania.
Hello. Hi, Silvia. Thank you for having me.
Yeah, Tania, thanks for being with us. I want to let everyone know that you are quite the big cheese here at APIC. You're a former APIC board member. You serve as the Director of Infection Control at Memorial Sloan Kettering in New York. And before that, you were the Director of Infection Prevention and Control at Westchester Medical Center. So I know you have a lot to share with your experience at those facilities and throughout your career. So welcome.
Thank you. Thanks for having me again.
We have Rosa Lozano, and she's with the Methodist Healthcare System located in San Antonio, Texas. And Rosa, you have been a volunteer with APIC for a number of years, and I know you currently serve on the APIC Communications Committee. You were very involved with APIC's public policy, so I know you'll have a lot to share.
Yeah, so excited to be here. Thanks so much.
Great. And finally, thrilled to introduce APIC's new CEO, Devin Jopp, Dr. Devin Jopp. And Devin joined us recently, and prior to coming to APIC, Devin, you were at the American College. Let me get this right. You were the CEO for the American College Health Association, correct?
You nailed it perfectly.
Okay. Well, welcome, Devin. All right. So today we're going to be talking about, as I said, the importance of diversity, equity, and inclusion. And I just want to set the stage for our listeners. Because it can be confusing. You know, what do we mean by equity? What do we mean? What is disparity? So really, let me just read this. Health disparities refer to the differences in outcomes or disease burden between disparate groups. So I think we can all understand that. And that equity, or the lack of health equity, is what is caused by those differences. So that's the working definition. Another important term to wrap our heads around is social determinants of health. And I am going to quote from the Centers for Disease Control, their definition of social determinants of health, which are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And what are those? Access and quality of healthcare, education access and quality, social and community contexts where people are living, their economic stability, their neighborhoods, the built environments in which they live. Those are all social determinants of health. Tania, does that work for you?
Yeah, I think that pretty much sums it up. And I think that's what we've been experiencing for a long time, but certainly it's been highlighted over this past year.
Yeah, I mean, there's a lot to break down here. The other thing I wanted to share, I thought this was kind of cool. This is from an article written by Bettina Danis, and it was from the American Society of Association Executives. And it's from a piece called "Your Team is Diverse, but Is It Inclusive?" And they quote someone as saying, "Diversity is being invited to the party, inclusion is being asked to dance." So, Rosie, what do you think of that?
I think it's pretty poignant. It's good to have the names listed on the piece of paper or the faces, in a visual format, but to actually seek the input, the opinions, the thoughts, the ideas of everyone that's part of the group is I think, probably where the most tension occurs, is ensuring that all those thoughts, ideas are included in the discussions and in the decisions that are made in an organization.
Yeah, so I want to talk a little bit. We're going to talk about infection prevention and control, sort of the global. How does this notion of diversity impact what infection preventionists do? And just to recap, so many of our episodes at the 5-second rule focus on, preventing infection. What are the outbreaks that we need to be concerned about? What are the pathogens? Infection preventionists work across the healthcare continuum, and while they're not involved in direct clinical patient care, they are working with other healthcare workers, other stakeholder organizations, public health. So I'm going to start with you, Tania, and ask, where do you see this issue of health disparities and inequity showing up in the infection prevention and control space?
Well, so Sylvia, I mentioned briefly just highlighting the COVID-19 pandemic over the past year plus and sort of the health equity and health disparity issues that alone has highlighted. I think it's a good example of how systemic the health disparities and health equity issues are in our nation, because it really elucidates in a very narrow spectrum some of these issues, or many of these issues that actually we can now tangibly talk about. We can now tangibly see the numbers and the statistics around it. So when you think about just the COVID-19 pandemic, you'll think about sort of, so where do minority communities get their health care? Usually in community hospitals that are disparate, that do not have the economics or the resources that some of the more reputable or academic institutions have. And so where they get their care may have, again, fewer resources, as well as fewer staff, as well as fewer opportunities for care, in terms of, world-class care that some of the more prestigious academic medical centers offer, but those centers are not available to those communities for care for many reasons, access being one of them, monetary access, physical access, being just to name a few.
Rosie, what do you say around not just COVID-19? What has been your experience in terms of what you've seen as an infection preventionist around unconscious bias or these disparities that lead to the inequity?
Sure. I think it's relatively easy to see disparities in our community as an infection preventionist. Typically, a hospital will serve different parts of the community. I work for a system of hospitals, and Some hospitals serve different parts of the community. And so you can see differences in population, differences in economic status, differences in culture, just hospital by hospital. And then within the hospital itself, it's easy to see differences in cultural aspects, economic aspects, just by looking at the different individuals who work within the hospital. Which department do they work for? And I think infection preventionists navigate these differences, navigate this on a daily basis. As an infection preventionist, it's really important that we understand and we know our audience, and we're able to communicate and educate in a way that resonates with whomever we're speaking to. And understanding understanding differences, understanding cultural norms, understanding, even just presentation and vocabulary that different individuals may need is really important to ensure effective communication that's really going to resonate with someone. So I think as an infection preventionist, we're used to navigating these differences. We probably don't even realize that we do it. It's just part of our job, because our work reaches so many different individuals, not only in the community, but within the hospital, employees and physicians and healthcare team members as well.
So what I'm hearing you say, Rosie, is an element of cultural competence and recognizing that staff, clinicians represent a huge swath of our society, whether we're talking about racial, gender differences, socioeconomic status, language. But I want to, that's interesting. And I'm going to share a personal anecdote around unconscious bias. And I want to get some reactions. And Devin, I am going to get to you. Many years ago, as a clinician working in a long-term care facility, okay, and I'll just say it, you guys know I'm Silvia Quevedo. I have a Hispanic last name. I was waiting for a call from a building maintenance person. At the end of the day, I was a little miffed because I hadn't heard back. And someone at the front office said, "Oh, Silvia, they called and we sent it over to housekeeping." So that's my personal anecdote to say, while we, there's that infection preventionist who is culturally competent, Tania or Rosie, I want to hear around some of the unconscious bias that may be present as infection preventionist, as you work with clinicians. Do you have a personal story or, reactions to what I said? Because I think you're right. I think you all do a great job as infection preventionists of talking to different groups, but let's really get to it and talk about what happens when we see unconscious bias or things get said that might put people in an awkward position. So I'll start with you, Tania.
So I think that we both experience and participate in unconscious bias. So I won't sit here and say that I have not myself, unconsciously biased people who are around me. I make an effort to not do it, but I think that, the best person is liable to fail. And so I think in my career, I've experienced unconscious bias, microaggressions, what I used to call subliminal racism, now is called microaggressions. And I don't think that I have ever experienced blatant racist remarks or actions against me. Most of these things are subliminal, and you feel it more than you can speak about it or say what the interaction was. And I see it in my staff. I see it happening with my staff, where you may have someone of a minority background versus someone who is non-minority or white. And it will automatically be assumed that the white counterpart is the knowledgeable one, or the one that is there to help on some higher academic level, versus the one who may be more experienced but is, of color. Um, and so I think that people participate in unconscious bias all the time. And I think that, our sort of our culture, the American culture, everything within media supports this. So how could they not? And I think it really is incumbent upon the person themselves to reflect and internalize and look at sort of what they are projecting. And I think that's what it's going to take, is really self-reflection independently and then as groups.
Okay. These are tough conversations. Rosie, what are your thoughts on that?
So I completely agree with what Tania is saying. I think, it kind of goes both ways. I know for me, an experience that I'll never forget is in my attempt to connect with a patient and the patient's family. I was speaking English to the patient and the patient's family, and their facial expression led me to believe that they weren't understanding what I was saying. So I switched over to speaking Spanish because I assumed that maybe Spanish was their native language and I would be able to communicate with them more effectively if I started speaking Spanish. And immediately the family member was clearly very offended and spoke up, which I appreciated, and said, "Listen, we're English speakers. We don't speak Spanish. Can you please continue speaking in English?" And that taught me really early on about, what assumptions mean, and something I could have done differently was simply ask. I have some information to discuss with you. Is there a language that you prefer? And leave it at that, rather than just assume and kind of put that poor family on the spot and kind of, put that family member in charge of speaking up and saying, "Whoa, stop." So I completely agree. It definitely goes both ways. I think what I appreciate about our conversations today is that they really do feel more transparent. They really do feel like, hey, listen, I may not know the right way to say this. I may not know the most politically correct words to use, but hey, I'm trying here. And I think that goes a long way with people and just starting the conversation. I'm so excited to hear more of that in my career experience, whether it's in volunteer organizations or where I work. And so, yes, absolutely. I think it does go both ways. Infection preventionists must be very aware of the way that we communicate and reach people. And likewise, those that interact with us must also be very aware of how we're spoken to and interacted with.
Absolutely. And, we started off by talking about inequities and disparities and infection preventionists. There's the personal story, the work setting, you as individuals and how you're either experiencing or, making assumptions as, human persons. We all are living that. We know that there are communities, that are under-resourced and therefore, as Tania, you were highlighting, aren't getting the care that maybe another person in another community may be getting. We know that, for example, healthcare-associated infections, can impact people of color, people with chronic illnesses. We're aware of things like diabetes. You're in the hospital, your infections, you're more prone to that. Who gets diabetes in the United States? There are communities that are more impacted by that. The pandemic shined a light on some of the disparities and inequities. But again, I want to go to Devin now because there's a lot happening at APIC, both at the staff level. So these are questions and conversations that the APIC staff is having, and Devin is leading that effort. But Devin's also working with the board of directors of APIC and working to sort of address these issues. So I'm going to turn to you now, Devin. And I want to get your thoughts first on this conversation and tell us what's happening in terms of where APIC is going to help its members address these issues. And I'm just going to say, Devin, I want to hear your thoughts. In preparation for this episode, I had a hard time finding some stats on where we are as, what we look like as an organization in terms of our demographic breakdown. So let me get your thoughts on what we've talked about so far.
Thanks, Sylvia. And it's a lot to unpack. And I think, a couple weeks ago, we actually had Dr. Sullivan, who did a webinar with us, who is a former secretary of HHS. And one of the big issues he really focused on was the long-standing systemic nature of social determinants of health and how do we get here, right? And so this has been over hundreds of years of inequity. And I think the repercussions that you and our panelists have hit on and seen it obviously culminate with COVID-19 is dramatic. And I think, it certainly requires us to start taking a hard look at ourselves, at our profession, of our work, and as an organization. And so a couple of things at kind of the higher level of looking at health inequity. I think we are really beginning the process of trying to put some more effort in around research and trying to better understand what this looks like. The data, particularly when you start looking at healthcare-associated infections, is rather limited. But the data that we do know, like for example from the National Library of Medicine, really is very poignant. And it does show that we are seeing, particularly in Hispanic, Asian communities with HAIs, we're seeing significant differences. But even infection prevention in a more macro general sense is obviously a huge issue that we see. And I think Tania alluded to this earlier, with Black Americans, we've seen that they're 3 times more likely to get COVID-19. Those are very real issues that we have to be able to address. And I think, with APIC, we have an opportunity as an association to drive this, lead it, and be change agents. And so I'm excited about this work. Within the organization also, I think we have a lot of work to do too. And I think, one of the things we want to be able to do is model the way and to be able to show as an organization how do we make that difference. And that's both at the staff and within our volunteer organization structure. And so the board of directors recently created a new task force to study this and to actually come up with recommendations for how do we make selections in volunteer roles, both for our board, for our committees, and various task forces. And that's important because I always talk about the issue of you have a little bit in organizations like ours, the jelly bean problem, right? Which is if you fill a bowl with 10 similar same color jelly beans and you add 2 different colored jelly beans, what kind of jelly beans do you generally pick when you put your hand in the pot, right? And so you have to be thoughtful and direct and really make a conscious change. You can't just kind of allow it to hope that it's going to emerge. And within the staff side as well, I think we actually as an organization have a very diverse organization. But that's on the surface because some of the challenges that we have, for example, is that we know the higher up you go in the organization, the less diverse we look, right? So we have a pathways challenge. And we've got to be able to A, understand it, and then B, measure it, and then C, take action on it. And so we're doing a lot of work around trying to create pathways for promotion and trying to really better understand how do we make a dent there. And I think as an organization, but kind of within APIC, that whole issue of measurement, Sylvia, that you brought up early on, is really crucial because I don't think that we're doing a very good job as an association yet of really trying to measure the problem and measure progress to making change. And I think, the good news is we're aware it's a problem, and I think we're on the path to beginning that journey. But I think when we start really tracking our measures around, how many candidates do we have for the committees that that we were looking at around their diversity? How many did we pick, right? What's our track record? What do we do around promotions in the organization? And then how do we publish this and keep ourselves as an organization honest about it, right? And we should be writing journal articles and other pieces around tracking our own progress. So it's a multi-level kind of attack on this, if you will. And I think, again, I'm very proud of our staff for the great work they're doing. Our board has really kind of initiated this work. And again, I think there's a lot of work on the research and implementation side that we also have to undertake.
Thanks, Devin. Tania, were you aware of some of these efforts happening at the National APIC office?
I was not, and I'm pleased to hear, actually. I've been out of the board now for about a year and a half, so I wasn't aware of some of these initiatives, but it's funny that Devin hit on some of the things that I wanted to hit on that APIC could do to sort of improve diversity, not only among the staff, but among the membership. I think over the 15 years that I've been a member of APIC, it has certainly become more diverse, but that has been unpurposeful, right? That has been by coincidence. And more diversity doesn't mean the right sort of levels of diversity, right? And are we being inclusive, and is there equity? And so I think both understanding the problems and measuring the progress is definitely going to get at some of those issues. So happy to hear about all of this.
Yeah, no, it is really an exciting time to be a part of APIC, both as a member and as a staff person. And Rosie, I want to ask you, what are your thoughts on what your perceptions are around the infection prevention and control community? I mean, you've been with APIC a while, you serve on committees. What are your thoughts on how we can increase not only the diversity, but that sense of engagement and inclusivity among infection preventionists that are of color or are men? That's another. Gender is a factor in our membership. What are your thoughts on that?
I think many of the points that Devin hit on are points that are going to help us on that path. I can speak about my own experience and what kind of motivates me to want to join a volunteer committee. And it's really about the message and whether or not the message resonates with me. But it's being very very purposeful about the messaging and the ability to impact the members that we serve, being able to impact the community, but ensuring that volunteers understand who's included in the community, who's included in the membership. I was recently asked to speak and produce a video that talked about diversity for my organization. And I was kind of on the fence. I didn't want to be recorded and just wasn't interested in doing that. And what made me change my mind was when our communications leader said, listen, there's a lot of young healthcare workers who are Hispanic, who will see you speak in a leadership role, and that will be very impactful for them, not only as an inspiration, but for them to understand that they can do this too. They too can get there. They can be featured in a video one day and be seen as a healthcare leader one day. And that's what changed my mind. And so I think, what's important is the communication of who do we serve in our organization. Devin, to your point, what are the statistics? And what I'm looking at, I would be looking at a, Hispanic patient population, Hispanic member population, but also to Sylvia, to your point, men, absolutely. I also am not a nurse, and sometimes not having the clinical background can also lead to a different kind of separation from different discussions. And so, how many of our members are not nurses, and who can I impact there? So I think just understanding what that data is, what the message is, what the impact is, I think is very, very impactful for anyone who wants to volunteer or serve with an APIC. I think a lot of our communications are very general, which works because you want to hit a very broad audience, but we may have the opportunity to expand some of our communication to serve different patient populations, different member populations, different types of healthcare facilities. We really focus on acute care. We probably have the opportunity to focus on other aspects of healthcare. So just, same communication, but in different formats and kind of stressing different points, I think, too, will just kind of help demonstrate we understand we serve a wide breadth of members, and we also serve a wide breadth of our community.
Great point. Devin, what do you think about what Rosie just shared?
Yeah, I mean, I think she's spot on. And I think, at the end of the day, if we really start, creating a framework for being able to measure and change the system, which is what we're talking about, right, at the end of the day, then setting benchmarks, setting goals, and then measuring progress. And let's face it, infection preventionists know a few things about goal setting. I think as a profession, we can really move the needle on this. And I think the other piece, too, that we also have to start thinking about, and we didn't talk much about, is this whole idea about how do we recruit new IPs? And how do we get them from diverse backgrounds and measure and make sure that we're also becoming broader in terms of all the aspects of what we've kind of talked about, both from a profession background, from obviously race, ethnicity, and I think really kind of creating that framework is really going to allow us to make some changes here.
So, Rosie, let me ask you, what are some things that you can do at your facility to address diversity, equity, and inclusion?
I think that's a great question. A few things I shared my experience about assumption and a language that someone speaks. I think just being cognizant of the assumptions that we make, and when we realize we're potentially making an assumption, flip that instead to an open-ended question. I think just asking questions is certainly going to help our understanding, our learning around diversity and inclusion. And so approach assumptions with a curious nature and ask questions, ask about preferences. On the flip side of that, I think when we experience something that may make us uncomfortable, it's important to role model how to give the feedback. And so, I think that's going to look different depending on what the experience is, but just being very cognizant that we're being watched, everyone's being watched, as leaders, we're watched, and be very cognizant about the way that we deliver feedback, because that's going to model what others do and how others provide feedback about something that maybe made them uncomfortable or something that was offensive.
Yeah, I think those are great points. Tania, what's one thing that you think you can do as an infection preventionist director at your facility to help support diversity, equity, and inclusion?
Yeah, so in a personal capacity, I wholeheartedly agree with Rosie about having those conversations and being forthcoming and transparent, as well as role modeling. I think that's very important. I think people like to see people that look like them. It encourages them and creates a pathway in their mind for them. I think personally, other things that I've been doing within my role is looking at our departmental internal hiring practices and who are we choosing versus not, and why that is, as well as pathways to leadership within the organization, but also within the department, and what that looks like. What has that been in the past, and what could it be, in the now or the future.
Great. And Devin, you shared a lot about what's happening at APIC National, but any other thoughts?
I think what we just heard from Tania and Rosa makes a lot of sense. But I think the other part is kind of within your institutions is actually measuring, and so building programs to actually be able to measure these kinds of changes, and how are we actually demonstrating progress in our institutions, both within our promotion and hiring practices, but then also even within kind of tracking HAIs and other infections. Making sure that we're looking at some of these key issues that we've kind of talked about here today.
Great. Well, you've heard it here, folks. Lots to do, lots of homework for all of us. Remember to check in at podcast@apic.org to share your thoughts, your ideas.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff and the APIC Communications Committee in partnership with Human Factor. Audio tech is Blake Alphin.